And so let me move on to some of the data from this phase 2 trial, which was completed a few months ago. The first thing I want to talk to you about is our ability to target tumor in patients, because this is, after all, really the core concept here. What you see on the screen here is the anterior and posterior bone scan of a typical patient with prostate cancer. You can see that the radionuclide used for bone scanning is excreted by the urinary tract. You see the kidneys here and the bladder, and these other sites you see, including in the skull, these other dark sites represent areas of metastatic prostate cancer. In this case, that's the injection site. I'm going to drop down this patient's antibody scan in between. So on the left half, you can see the anterior studies side by side, and on the right side of the screen, you can see the posterior studies. And what you can see with this particular isotope is excretion is through the liver, not the urinary tract. But the more important point is that everywhere you see a lesion on the bone scan, you see the radiolabeled antibody is targeting all of those lesions, and it should be pretty obvious. I hope it's pretty obvious to everybody that you can see many more lesions on the antibody scan than you can see on the conventional bone scan. This does appear to be a more sensitive modality. Just to give you one more example, again, same setup. Everywhere you see a bony metastasis in this prostate cancer patient, you can see that we can target the radiolabeled antibody to those tumor sites. And what you should understand goes beyond the ability to image. What you should look at this and think to yourself, I believe, is that we're no longer delivering a systemic therapy to every cell in the body, as you would get with chemotherapy. What we are doing is identifying the tumor cells and targeting the tumor cells to the exclusion of normal cells. These arrows simply, again, point out areas of tumor that show up on the antibody scan, but not the bone scan. And we've seen this in many cases and have confirmed that these are true positive lesions, not false positive lesions. So what's the data in this phase 2 trial? Well, of the 32 patients, 94% of them showed successful targeting of tumor sites. Just as in the phase 1 trial, it was very well tolerated. We saw the predictable and reversible decrease in platelet counts and decrease in polymorphonuclear cell counts. We saw no bleeding episodes and no episodes of what is referred to as febrile neutropenia, and there was no serious non-hematologic events. This is an example of one of the patients in the trial. This patient had rapidly progressing prostate cancer. It was demonstrated by his PSA doubling time of 3.9 months. This was actually one of the longer doubling times in the trial. This is considered a very rapid rate of progression. Again, in the images on the left of the screen, you can see every site of tumor is targeted by the radiolabeled antibody. And on the right side, you can see his PSA both on a logarithmic plot as well as an arithmetic plot. And this patient had a 90% decline in his PSA. This is a summary of all of the patients in the study. This is what's called a waterfall plot, very commonly used to display clinical data in cancer these days. Those in red were at the higher dose, and those in blue were at the lower dose. And you can see that the higher dose patients, even though there was not a substantial difference in the dose, only a 7% difference in the dose, but nevertheless the response rate was clearly better at the higher dose. And that's demonstrated again here, where if you look at the maximum tolerated dose, the significant PSA response rate, this is the threshold, virtually half of the patients had a significant PSA decline, and in fact, almost 2/3 of the patients had a PSA decline, which is consistent with significant improvement in survival. We found by going back retrospectively that patients who had not had, I can't see from here, these patients had not gotten chemotherapy, the response rate was even higher. And in patients who had had prior chemotherapy, as one would expect in an oncology trial, prior treatment makes patients more resistant to therapy. But almost every patient who had not had prior chemotherapy had a response. So where are we going with this? Well, we're making efforts to increase the dose to get better responses, and we are just concluding a trial now, a phase 1 trial where patients get multiple doses of the agent. In addition, in the past few months, there have been 2 platelet growth factors which are the first in class to be approved by the FDA, so we may be able to increase the maximum tolerated dose by incorporating platelet growth factors with these agents. In patients who have clear metastatic disease, we are about to combine that with the standard chemotherapy in this setting, which is docetaxel, which in its own right improves survival, and as I alluded to earlier, is a radiosensitizer. But closer to our ultimate goal is we've just gotten Institutional Review Board approval to for the first time, apply this lutetium radiolabeled antibody to patients who are more amenable to this treatment, that is, patients who have microscopic disease. So we are soon to embark on a randomized controlled multi-center trial. This will include patients who have failed surgery, prior surgery, or radiation therapy. They will have also failed early hormonal therapy. They'll have rapidly rising PSAs or high levels of PSAs. And we know in this patient setting that half of those patients will have frank metastatic disease on their scans by 18 months. We're going to enter 140 of those patients across the country, and those patients will be randomized in a 2-to-1 fashion to get either the conventional last-ditch hormonal therapy, which is ketoconazole plus prednisone, with or without the radiolabeled antibody, looking at an endpoint of time to developing metastatic disease with a goal to decrease the incidence of metastatic disease by 50%. And so I'm probably way over time here. I'm going to wrap up by saying that this therapeutic approach is extremely well tolerated by the patients. As I said earlier, they have no symptomatic side effects from this. The only side effects are those that we can detect on blood counts. We can accurately target 90% of unselected prostate cancer patients. We see significant anti-tumor activity despite the fact that to date it's only been applied in patients for whom we would consider significantly suboptimal because of the extent and bulk of their disease and because most of them have had prior chemotherapy. And there is significant potential for synergy when we combine this with the standard cytotoxic agent, and there is potential to have a significant impact in the very large number of patients in this country with microscopic metastatic disease. Thanks very much.